So, hello everyone, and welcome to very tough time presentation. The number of audience shows how it tough. However, I am Rosie from Partners in Health and Development, representing Bangladesh, and presenting here the Bangladesh urban primary healthcare context and an innovative model of service delivery. Though very few are there, but any of you would like to live in a sick city? Any of you? Must be no. But the city people in Bangladesh, especially the capital city Dhaka people, are currently experiencing that due to the high rates of urbanization and that have the bad impact on urban health. And as such, currently the urban primary health care is fragmented and I must say, neglected as well. As per World Bank Report 2018, the urban population ratio is going to rise to 39%, and it is assuming that it will exceed the rural population of the whole people in 2040. But considering all this scenario, no sustainable healthcare service delivery mechanism is developed for urban health. Though people in rural Bangladesh experience a very good structure of health system delivery, but it is completely absent for urban. And taking this gap as an opportunity, huge private sector health services developed that resulting to high rate of out-of-pocket expenditure. In 2019, the highest rate of out-of-pocket expenditure experienced by Bangladeshi population, and that is 74% of whole health expenditure. And definitely, it has very bad impact on poverty status of the country. So, isn't working? Okay, thank you. Oh. So what we have currently in our primary healthcare system that have high attention on curative care, especially for secondary and tertiary level, very low attention on primary healthcare. The preventive, promotive, palliative, and the public health is completely ignored. No health referral, no health record exists, that resulting to very lack of evidence-based decision-making and planning. Okay. As said earlier, the Dhaka people has the high impact, but there too, the experiences are a bit diverse. As Dhaka is a city of mixed population in terms of migration, employment opportunity, administrative structure, etc. In this slide, I'm going to present some statistical data on Dhaka urban health scenario and comparison between slum and non-slum health. As in the first graph, you can see that women living in slums are much less likely to receive antenatal care, that is the 36%, than that of non-slum women, that is 61%. Similar thing is happening for delivery attended by unskilled birth attendants. That is again the highest number exit at the slum. The stunting, underweight, everything is existing highest number in the slum than that of the non-slum areas. Though we are doing good in vaccination coverage, but there too, the city coverage is lower than the national coverage. So these are some of examples, but the total urban health scenario is really damaging. Considering all these diverse pictures and ground challenge, realizing the need of having a sound urban health policy, reflecting the country context of rural-urban migration, the shift in urban health and demographic profile, Government of Bangladesh has developed National Urban Health Strategy 2020. The first National Urban Health Strategy was developed in 2014 under the leadership of City Corporation, but this time it is developed and approved by Government of Ministry of Health and Family Welfare, and it is their responsibility now to work for betterment of urban health. Under this national strategy, The urban primary healthcare framework has opportunity to emphasize on some few focused areas. It has spatial entertainment for the poor and for better healthcare financing, exploring opportunity for public-private partnership opportunities too. Improve number and quality of public health facilities to provide primary healthcare, targeting healthcare needs of slum people, street people, floating people have the opportunity to design health delivery systems. And again, some additional emphasis on some service provisions too, like non-communicable disease receive greater emphasis in essential service package delivery provision. It has provision for providing supplies for family planning, nutrition, immunization, and other public health interventions. Most importantly, giving emphasis on developing and functionalizing of a structured referral system. We are still working on few more areas too, as the coordination gap among ministries would be a bigger challenge for Bangladesh. Thus, there is a need to have a standing committee led by city corporation to make the things operationalized. In order to increase the number of primary healthcare centers, the urban health dispensaries need to be established after proper mapping. Regulatory framework need to be enforced from registration, licensing to monitoring and evaluation of quality health service delivery. Satellite service need to be initiated to make the services at the doorstep of the people, along with social behavioral change communication approach. Keeping all these things in mind, we are now going to present to implement our implementation model of a very innovative health service delivery model that through our ALO clinic. ALO is the Bangla meaning of English word light, and we hope and believe that the brightening shine of this ALO model will surely enlighten our urban health status. So this part of the innovative model is going to be presented by my colleague Masuda Begum, and I should stop here. And thank you all for your patience hearing. Thank you.
Respected audience, very good afternoon and assalamu alaikum. Welcome to my presentation. This is Masuda Begum. My organization name is Nari Moitri, and now I am representing from Aluf Clinic. As Ruziapa mentioned, Alu Clinic. This is pilot project, model urban PSC project, that is Alu Clinic model. This project is designed by UNICEF with a 5 members technical group team. They are visiting all the primary healthcare centers and other facilities in urban areas, and conducted lots of workshops with government and other stakeholders, and they finalized a design for a model which we want to implement in urban area. And this for this project funded by Embassy of Sweden, and clinic operation or service delivery started from December 2021. Implementing partners is government, Ministry of Health and Family Welfare, Ministry of LGRD and CLGI, DGHS and DG Family Planning, operationalized by PhD, that is Partners in Health and Development, Nari Moitri and CMED Health. Implementation research partner, there is implementation research with this Alu Clinic from doing by ICD DRB. And we are in monitoring, external monitoring by TGT, technical guidance team, those who designed this project. We want to say this is an unique project. Why? Unique feature of Alu Clinics. This project stewardship by government through project implementation committee at DGHS with inclusion of city corporations led by additional director of DGHS. Access to service enhanced to 2 shift of services. This clinic started from 8:30 a.m. and ended up 9 p.m. at night. And the quality services and gender sensitivity addressed by ensuring 1 female and 1 male GP. GP means general practitioner. In each shift. Each shift we have 1 male GP and 1 female GP. Paperless healthcare through IDSP, integrated digital health platform, explore opportunities for real-time data generation for monitoring and planning, integration with National Health Portal, that is DHIS2. Free of cost services that cover ESP services, digital screening with smart POCD, limited diagnostic services of Allo Clinic, primary medicine, and outreach services. All the services are free. And POCD means point of care diagnostics. Referral link is for clinical services and diagnostic to the government, that is public hospitals and private diagnostic centers. And others is social behavior change communication. Service coverage. What is design? Service coverage for better management of assignment, the entire geographic area divided into 2 zones. South zone and North zone. South zone means Dhaka South City Corporation and Nanjangud City Corporation, and North zone is Dhaka North City Corporation and Gazipur City Corporation. South City Corporation have 2 Allo clinic implementing, that is Dalpur and Shampur, and Narayanganj City Corporation is Tanbazar Narayanganj. North City Corporation is Korail, that is Bonani, Korail and Mirpur, and Gazipur City Corporation is 1 clinic, that is Ershad Nagar. There is all the people of the catchment area is our target, but special attention is pregnant mother, lactating mother, infant, under 5-year children, adolescent, women, and especially old age and elderly problem is coming in our country, so that our priority is a non-communicable disease is more high in Bangladesh, so that elderly people is our most important target. This is ward-wise distribution of our Allo clinic. Here is a catchment area population and other under-year children. This is target population. Yes, for fourth sector program, health program is the essential service package. We cover all the activities with our Allo clinic, by our Allo clinic: maternal, neonatal, child and adolescent healthcare, nutrition services for children, adolescent and mother, non-communicable disease control, and management of limited curative care, behavior change communication, family planning, communicable disease control, and laboratory services. All activities covered by our Allo clinic, among all the services are free of cost. This is our service flow of Allo clinics. Okay, left side, this is our community, and then show na? Mouse, no. Okay, left side, this is our community, and then our Allo clinic and waiting area, and there is a clinic assistant, though she registered our clinic with okay. This is waiting area, and start from here. This is our community, and this is our Allo clinic. This is waiting area, and this is the paramedic area, which is vital screening, checkup and screening. This pressure, blood pressure, random blood glucose, height, weight, oxygen situation is all the patient. We conduct that type of screening and then refer to the doctor. Those doctor may be three issue. If serious case, doctor can refer. If normal case, doctor can treatment, and other than doctor can refer to our laboratory. Laboratory technician test their doing their test and then upload the report at the IDSP, and then report go to the doctor. Doctor can see and then prescribe the patient. After that, doctor prescribe the medicine and patient go to the paramedic for medicine, and after receiving medicine, patient go to the community and their house. This is an integrated digital healthcare platform IDSP deployed. This is a system. Why we are saying the paperless? Paperless means we have one paper that is only prescription for the patient. Develop deployed functional IDSP, that is mobile apps function through tab, that for paramedic, lab technician, clinic assistant, nurses, for others. Web application functional through laptop, it is for doctors. Used mobile apps and smart POCD for clients. POCD means point of care diagnostics. And registration and healthcare. Use web application for digital prescription, and we have satisfaction kiosks. For there is an opportunity for patient, she can give their comments, give their opinion, whether they are satisfied. This is either if she satisfied, it's a green signal, so or she silent, or she is not happy, she can mark there. If she gave, I'm not happy, and then some comments come, why you are not happy, please mention. There is an opportunity, client can monitor us. And integrated HMIS operationalized and reporting to DSIS2 from January 2022. This is dashboard. It is October 24 October. That time, that is our unique patient 53,302, and consultation provided by doctor it is 7,843, and patient receiving counseling GP. Yesterday was a cyclone. There's a patient at there, and please click the link, please. দিতে পারবে, শিখিয়ে দিচ্ছি। Yes, yes, coming. Yes. Is it now? At this moment, what is Alo Clinic doing? This is yesterday new patient, where it was cyclone yesterday and weather was not good. It's only 6 clinic, only 150 person, and today till now there is a 281 person is a new patient, and doctor prescribed yesterday only, sorry, why she today is 600 patient already seen in doctor, It's a follow-up patient and new patient. This is a new patient, and including all patient is 600. Is it today till now? This is a real-time monitoring. You can see the patient and total and the counseling. It's a laboratory services and referral. And also, this is a 99.6% patient are satisfied, and rest of them are not satisfied. And this is laboratory services. You can see also the dashboard, inventory, claim information, clinic survey, other report, DSIS2, etc. And doctors, all the services you can go. This is technical problem, so I don't go to details. Please close this. Just minimize. Yeah. What's the question?
Next slide.
Yes. Next is we have our outreach services. Our outreach services name is Durgurai Shastha Seva. That means health services in your doorsteps. And we have 4 city corporation. We have 4 satellite band and 4 satellite team. And they 6 in a week they work, and 36 spot they are covering with the satellite band. And they are not only servicing, promote ALU clinic and services, registered client, digital health screening, MNCS, SRS, and NCD counseling, family planning services, also counseling, nutrition services, also cultural counseling, refer to respective ALU clinics and provide EPA services. Clinic by this project, after contest analysis, determining the target audience, stakeholders, and is now being registered, there is designing the BCC materials and develop SBCC strategy will address to situational challenge and meet their requirements. Okay. Yes, it's a way forward. What can we do? As this model is being piloted, the lessons and the learnings is being recorded and documented by an independent team, implementation research team, ICDDRB, for future scale up by the government of Bangladesh. This is some photo of our services. It's the only photo. And thank you for all. If you have any question, we will try to give answer. If problem, Margov sir is here. Everybody you can give answer. Thank you so much.
Thank you, Masuda Appa. We will have an exclusive question answer session. However, at this moment, if you have any burning question, we can address that. Oh, please.
With the satisfaction survey, I know you had the punch buttons, but then you also had it looked like an app next to it. Do patients have access to that app, or did you say it was only for healthcare providers?
Basically, it is a kiosk with 3 signs. One is smiley face, that means satisfaction. One is neutral, and another is unsatisfied. So for first 2, there is no other drop-down box, but the last one, that is unsatisfied, there is a drop-down box. There are 5 or 6 options patient can choose why she or he was not satisfied. So that drop-down box gives the clue. So he or she can click on whatever the reason he or she was not satisfied. That's how it works. Okay.
All this system, web system, like if it is an app, does it have access of the health service providers as well as the beneficiaries and others, isn't it?
Yeah, just so, like, say I was unhappy,
Mm-hmm.
how would they get back to me with the resolution? So is there sort of a two-way way of communicating with the patient?
Yeah, please.
in the original design, we have both way communication allowed in the design, but till today, we didn't launch that option for our beneficiaries. Till today, the apps is only for the service providers, but we have planned to even open it for our beneficiaries too. Through mobile app, they can enter into IDHP. Dashboard is visible to each of the relevant stakeholders. They have access, but they can't edit anything, edit or delete anything. They can only have the visuals of the dashboard.
Okay, thank you. So thank you very much, Masudapa and Rosie, for your excellent presentation. We have learned many things like rapid urbanization and the problems of urban health that exist in Bangladesh, even the immunization, which is the most successful program in Bangladesh. However, it lags behind in the urban areas. These are the issues. So now I will invite our another Reverend presenter, Mr. AFM Alauddin, Joint Secretary and also Project Director of Urban Primary Healthcare Service Delivery Project. He will talk about his project. Thank you.
Good afternoon. Honorable Chairperson of this plenary session, Mr. Mustaqibullah Farooqi, Honorable Additional Secretary, Ministry of Local Government, Government of Bangladesh, members of the delegation from Bangladesh, other participants, guests, ladies and gentlemen, I welcome all of you in the 18th International Conference on Urban Health. I'm the only people representing on behalf of the government of Bangladesh to delivering the primary healthcare service delivery system in Bangladesh. So it is my responsibility how to implement and scale up community-based solution for improving urban health in Bangladesh. So I'm going to start my presentation. Yeah. Points to note to implement and scale up community-based solution for improving urban health. Community engagement and people's participation is most important things to complete or to provide primary healthcare service delivery. Understanding the level of people's participation is an important consideration in developing a community engagement strategy. Other than participation of the people or mass people, it is not possible to ensure the whole system. And levels of community engagement. Who are the community members and what are the levels of their engagement? And empowerment is considered a level with the highest degree of participation. And aims of community engagement. What is the aims of community engagement in service delivery system? The community develops self-reliances. The community develops critical awareness. The community develops problem-solving skills. If there is no problem-solving skills in the community level, the program will not be succeed. Then community engagement approaches. Approaches have different objectives. There are some objectives of community engagement, that is to prevent disease, to ensure that people well informed and are able to make health choices, and to help people acquire the skills and confidence to take greater confidence over the health, and to change policies and environment in order to facilitate healthy choices. If the people cannot choose their select their own choice, it will not be possible to ensure perfect health service system. So community engagement is very much needed. There are strategies to implement and scale up community-based solution for improving urban primary health in Bangladesh. The question is where we are, whether we are in the right track or not, and what are our dream and what we should go and what type of programs we should taken for completing the urban primary healthcare service delivery properly. That is, in our last presentation, Mr. Shamim Talukder was stated that Bangladesh is an urbanization at a rapid pace of countries. Urban population increases more than double from 21.3 million to 52.1 million between 90s and 2022. Ratio has increased from 19.8 to 39.4. But nowadays, the ratio is increasing day by day. By 2030, it will be 45%, 45 to 55. This ratio will be in urbanization. By 2030, the urban population is expected to be 98.9 million and comprises a majority 50-50 of the total population. And rapid urbanization, although an important contributor to economic growth, place in enormous demands of health and social services in urban areas, particularly on urban local bodies. That is, in our country, there are city corporations, Paur Sabhas, and Union Parishad, but we are talking about urban health, so that city corporation and Paur Sabhas are the urban local bodies who provided basic amenities and primary healthcare services. And the present provision of primary healthcare service delivery in the urban area under the urban local bodies is not enough to cope up with the increasing demand due to shortage of manpower and budget. Then mandate of urban local bodies, that is Union City Corporation, Paur Sabhas, and sustainable urban primary healthcare in line with the National Urban Health Strategies 2014 of Bangladesh. As per the Local Government City Corporation Act 2009 and the Municipality Act 2009, the mandate of primary health and public healthcare and public healthcare activities lies with the urban local bodies. That is, the population, the people living in city corporation and Paur Sabha areas, the city corporation and Paur Sabha authority is mandated, is bound to deliver the primary healthcare services to their city dwellers. And LGD, Ministry of Local Government, with the support of ADB, has been assisting urban local bodies in providing public primary healthcare services in urban areas for about the last 24 years, not 20 years, 24 years under Urban Primary Healthcare Services Delivery Project Phase 1 and Phase 2. You know, it is the mandate of the urban local bodies to deliver all the primary healthcare services to the city dwellers, but still they have the capacity to build up their sustainability to give the service to the city dwellers. So it is the responsibility of the ministry to ensure the service delivery to the city dwellers by city corporation and Paur Sabhas, so that the government of Bangladesh has planned to make a loan agreement with our development partner, Asian Development Bank, ADB. And since 1998, a program is going on to provide the primary healthcare services delivery to the city dwellers by Urban Primary Healthcare Services Delivery Project. As a result, sustainability of providing primary healthcare services after this project is one of the main focus on Urban Primary Healthcare Service Delivery Project Phase 2. And under Urban Primary Healthcare Services Delivery Project Phase 2, contracted private NGOs is working in the selected partnership agreements, which I can tell that the city corporation and Paur Sabhas has no manpower. They have no logistics. They have no manpower, logistics, and infrastructure. That's why the Ministry of Local Government has planned to outsource people to delivering the services. So partner NGOs has been selected, and by their population and other service providers, we have made these services to the city dwellers from 1998. Each city corporation and selected municipalities are the implementing agency, that is PIU, and responsible for the execution and implementation of the components of the project in their respective geographical areas. You know, in our country, under the Urban Primary Healthcare Service Delivery Project, there are 45, according to the DPP, about 45 partner areas, and we have selected some NGOs to delivering the services in this partner area. Double head. The chief health officer of the city corporation and the chief executive officer of the municipalities are the ex officio project manager of Urban Primary Healthcare Services Delivery Project Phase 2. In city corporation and municipalities, health officer will be assigned for the position of project officer or PO. For each partner area, the selected partner NGOs will ensure proper staffing of comprehensive reproductive healthcare centers and primary healthcare centers, satellite clinics, and partner NGOs office under its jurisdiction. To empower the urban local bodies and ensure more ownership and sustainability of urban primary healthcare services delivery program, in the absence of project, 5 partner areas are out of 45 partner areas have been identified by the GOB and ADB on a pilot basis for the development of authority for direct management and disbursement of fund, monitoring and reporting of urban primary healthcare services delivery project. And specific objective of urban health project, that is improve accessibility, financial and physical, to primary healthcare services for the urban areas covered by the project. You have heard earlier that out-of-pocket expenditure in the urban areas are very high in Bangladesh, but the people living in the urban areas, they are the distressed people driven out from the what I should say, the periphery of the country, and they are living in the urban areas, but their lifestyle and life expectation is very low. So that's why these people will be taken their primary healthcare services from this project, and the accessibility is ensured by that project. And ensure the delivery of quality primary healthcare services to urban population, the project will ensure essential service delivery package ESD plus focused maternal and child health in urban areas, particularly for the poor, which I said earlier. Increase of utilization of primary healthcare services by the urban poor, especially women, newborn, and the children. There are 3 components of urban primary healthcare services delivery project. There is one is for the reproductive healthcare, one is nutrition, and other is adolescent healthcare. And strengthen institutional arrangement for the delivery of primary healthcare services in urban areas, and increase capacity of the urban local bodies to ensure the delivery of primary healthcare services according to their mandate. That is, a project cannot be run over the years. So it is the responsibility of the urban local bodies to take the continue the service to the city dwellers for their own, so that they have to institutionalization capacity development for the delivering services of urban primary healthcare, and increase sustainability of the delivery of urban primary healthcare services by strengthening ownership and commitment of the urban local bodies to ensure the delivery of primary healthcare services, particularly for the poor. Strategies to be achieved by 2023. A British attended by skilled health personnel in urban areas will be increased from 63% to 75%, and under 5 children under age of 5 children in urban area who visited health centers received nutritional screening measured on entrepreneurship will be increased from 64 to 80%. And at least 80% of urban poor households are properly identified as eligible for free healthcare. They will be getting their healthcare service free of cost. And role and responsibilities of the implementing agencies, that is IA selected UL base. The 11 city corporation and the 14 selected municipalities are the implementing agencies and responsible for the overall execution and implementation of the project through their health department, who are working as per implementation unit, as per project management and according to DPP, which I have said earlier. And what are the committees? Under the ULB, there are ward committee and there are committees headed by the Honorable Mayor, and also the ward committee headed by ward councillor. There are every month they have conducted the meeting to monitor and to scale up the primary healthcare services delivery to the city dwellers, whether their satisfaction is good or not. They have monitored it and report to PMU, project management unit, that is project director, and project director accordingly take the initiative to improving the delivery primary healthcare service delivery system. And functions and TOR of the ward urban health coordination committee, which I have said earlier. Sustainability fund. In designing in the DPP, there is a sustainability fund will be created by the PNGOs, and it will be deposited to the urban local bodies. By this fund, they will continuing their services to the city dwellers if the project is not exist. And I said earlier that a project cannot be run over the years or for a long time. If the project has been finished, the responsibility will be the urban local bodies will take the responsibility to continue the services. And it is not developed a catchment area map of partner areas with showing major and other facilities, including urban primary healthcare services delivery facilities, and apply pull or push strategies and more or even 100% rate card distribution through ULB. In the present situation, 30% of the population in the catchment area will get free of cost with red cards, but we have a plan. The city corporation and Purosabhas will take the responsibility that they will provide the service free of cost for all the population of the city corporation. And this is why this is all of my presentation. If you have any question or any queries, you can raise. Thank you very much.
Thank you, Mr. Khan, for your informative presentation. You want to ask something? Yes. Please.
বাংলায় বলতে চাই। হ্যাঁ, আমি দেখলাম মানে হচ্ছে যে আরবান হেলথ আপনার প্রেজেন্টেশনটা খুব সুন্দর চমৎকারভাবে ফুটে উঠেছে আর কি। যেটা ধারণা পেলাম যে মানে একটা হচ্ছে যে আরবান হেলথটা এখন মোস্টলি হচ্ছে যে প্রাইভেট সেক্টর নির্ভর, ঠিক আছে, এবং হ্যাঁ স্যার রাইট, মানে হচ্ছে যে এবং যতটুকু প্রজেক্টের সাথে চলছে ওইটা হয়তো আমরা চেক করে দেখতে পারি আমরা কতটুকু কন্ট্রিবিউট করতেছি আর কি আরবান পপুলেশনের জন্য। এটা খুব ইম্পর্টেন্ট যে দেখা যে টোটাল আরবান পপুলেশনের জন্য আমরা কতটুকু কন্ট্রিবিউট করছি, তাহলে হয়তো আমাদের একটা ফিডব্যাক আমরা পাবো যে আসলে আমাদের কি করণীয় আছে। এটা একটা বিষয়। একটা হচ্ছে যে মানে আমাদের মানে ডাটাবেস যাদের জন্য আমরা কাজ করছি তাদের মানে একদম অ্যাকচুয়াল ডাটাবেসটা আমাদের আছে কিনা আর কি। হ্যাঁ, বিশেষ করে আমরা দেখলাম যে পপুলেশন সেন্সাস যেটা রিসেন্টলি বেরিয়েছে স্যার, ঢাকা সিটি কর্পোরেশন 2 সিটি কর্পোরেশন মিলে মোর দেন 1 crore, মানে 1 কোটির উপরে পপুলেশন ঢাকা সিটিতে বসবাস করে আর কি, ঠিক আছে স্যার? আচ্ছা ওকে স্যার রাইট হ্যাঁ তো এখন যেটা হলো যে এটা একটা বিষয় এবং এখানের মধ্যে হচ্ছে যে আমাদের এটা হচ্ছে যে একদমই মানে রেজিস্টার্ড যারা বলছি বাট অনেকে ধারণা করে যে ঢাকা শহরে প্রায় 1.5 কোটির মতো লোক বসবাস করে আর কি এবং এই বাসমান লোকের কথা যেটা স্যারের কথাও আসছে কিছুটা যে আসা যাওয়ার মধ্যে আছে এরকম পপুলেশন আছে আর কি, যারা ইসলামে বসবাস করে। তো আমাদের কাছে আসলে এই যে আমরা একদম বেশ পার্টিকুলারলি যদি বিশেষ জনগোষ্ঠীর কথা বলি মা এবং শিশুদের তাদের কোনো ডেটাবেজ আমরা করতে পেরেছি কিনা তাহলে হয়তো বা এটা বোঝা যেত যে এদের মধ্যে আমরা কত পার্সেন্টকে আসলে আমরা রিচ করতে পারছি। আমাদের বলেছে যে ইপিআই কভারেজটা ভালো, এটা বলেছে। আর একটা হচ্ছে স্যার একটা হেলথ গভর্নেন্সের কথাও বলা হয়েছে যে সিটি মানে ওয়ার্ডের নেতৃত্বে একটা কমিটি আছে, কমিশনার সাহেবের নেতৃত্বে আছে, ঠিক আছে, এবং সেটা মূলত দেখলাম যে হচ্ছে যে এই ক্লিনিকটা বা এটার সাথে যে রিলেশনটা আছে কাজে সেই সম্পর্কে কথাই বলা হচ্ছে, সেখানে তাদের রোলটা কি হবে আর কি। কিন্তু পার্টিকুলারলি যে তার ওয়ার্ডে যে স্বাস্থ্যের যে সমস্যাটা আছে ওইখানে যে হেলথ গভর্নেন্স সেখানে তার যে কন্ট্রিবিউশনের ব্যাপারটা আছে মানে সেখানে কিভাবে সিটি কর্পোরেশন আরো ভালো রোল প্লে করতে পারে এবং হচ্ছে যে ওভারঅল আমি যদি বলি যে স্যার সিটি কর্পোরেশন তো একটা মানে নির্বাচিত ইয়ে এবং তাদের একটা বার্ষিক বাজেট হয় এবং তার টোটাল যে বাজেট সেই বাজেটে সে কত অংশ আসলে সিটির নাগরিকদের জন্য খরচ করতেছে স্বাস্থ্য খাতে, ঠিক আছে। আর স্বাস্থ্য বলতে আমরা শুধু খালি কি প্রাইমারি হেলথ কেয়ার বুঝবো নাকি এর সাথে আমাদের নিউট্রিশন ইস্যুটা আছে, এর সাথে ওয়াশ ইস্যুটাও আছে, ঠিক আছে। ওয়াশ কিন্তু স্বাস্থ্যের একটা গুরুত্বপূর্ণ পার্ট, ঠিক আছে, আমরা কোনোভাবে এটা ইগনোর করতে পারি না। আমার স্বাস্থ্যের সাথে নিরাপদ পানি এবং সুব্যবস্থাপনা যেটা পয় নিষ্কাশনের কথা বলছে এটা একদম পারস্পরিক সম্পর্কিত। এবং সম্প্রতি আমি যতদূর জানি বাংলাদেশ ন্যাশনাল নিউট্রিশন কাউন্সিল একটা আরবান নিউট্রিশন স্ট্র্যাটেজির জন্য কাজ করছে আর কি, ঠিক আছে। সেখানেও মনে হয় স্যার লোকাল গভর্নমেন্ট অথবা ভালোভাবে কন্ট্রিবিউট করতে পারে, সংযুক্ত হতে পারে যে এখানে সিটির নাগরিকদেরকে। সো আমার স্যার বেশি ফোকাস থাকবে যে আসলে যেমন একটা ঝুঁকির কথা স্যার বলছে যে যদি প্রজেক্ট বন্ধ হয়ে যায় তাহলে এটা আসলে কি হবে, এটা ফিউচারটা কি হবে, আমরা কি ছেড়ে দিব কিনা এতগুলো মানুষের। কোশ্চেনটা শেষ করে দিচ্ছে স্যার যে এই নাগরিকদের, তাহলে এতদিন স্যার এইখানে আমাদের আসলে কি আপকামিং আপনাদের দিক থেকে আছে যে যেটা নিয়ে আমরা বলতে পারি যে হ্যাঁ দেয়ার আর সাম মানে ডিসিশন আসতেছে যেটা হয়তো বা টেক ওভার করবে যদি প্রজেক্টটা বন্ধ হয়ে যাবে, নাকি আমরা প্রজেক্ট বেজে থাকবো, প্রজেক্ট থাকাকালীন সময় আমাদের আসলে কি প্ল্যান যে প্রাইমারি হেলথ কেয়ারটাকে নিশ্চিত করার জন্য। এইটাই ওভারঅল স্যার এটা আমার একটা কমেন্টস। থ্যাংক ইউ।
Thank you very much for your innovative question and some it doesn't work.
It's working.
Okay. আপনার চমৎকার কিছু প্রশ্ন এবং কিছু সাজেশনের জন্য অনেক ধন্যবাদ। আপনাদের জানিয়ে রাখি মূলত যে আরবান প্রাইমারি হেলথ কেয়ার সার্ভিসেস ডেলিভারি প্রজেক্টটার উৎপত্তি হয়েছে মূলত আমাদের যে সংবিধানের 59 অনুচ্ছেদে বলা আছে যে আমাদের সরকারের কাঠামোর মধ্যে স্থানীয় সরকারের ব্যবস্থাপনা থাকবে এবং প্রতিটি ক্ষেত্রে নির্বাচিত জনপ্রতিনিধিদের মাধ্যমে লোকালি তারা বিভিন্ন প্ল্যানিং করে তারা তাদের নাগরিকদের জন্য বিভিন্ন রকম সেবা প্রদান করবে। ওরই অংশ হিসাবে 2009 সালে এসে আমাদের মহান জাতীয় সংসদে একটি আইন পাশ করা হয়, স্থানীয় সরকার সিটি কর্পোরেশন এবং স্থানীয় সরকার পৌরসভা আইন। সেই আইনে পরিষ্কার বলে দেওয়া হয়েছে যে সিটি কর্পোরেশন এবং পৌরসভা এলাকায় বসবাসকারী জনগণের প্রাথমিক স্বাস্থ্য সেবা, স্পেশালি আমি যেটার কথা বললাম সেটা হলো যে ওই যে হাইজিনিটি, মশা মারা, নিষ্কাশন, তারপরে হলো যে আপনার এই যে মা এবং শিশুদের জন্য সেবা এবং নিউট্রিশনের কথা আগেই বলেছি। এই সেবাগুলি আমাদের সিটি কর্পোরেশনের অন্তর্ভুক্ত যে এরিয়াতে জনগণ বসবাস করে তাদের সিটি কর্পোরেশনের আমব্রেলার মধ্যে এই সেবাগুলি প্রদান করা হবে বলা হলো, কিন্তু তাদের সেরকম প্রস্তুতি ছিল না। কারণ এই সেবাগুলি যাদেরকে দিয়ে প্রদান করা হবে সেই জনবল কোথায়? জনবল স্থানীয় সরকার কাঠামোগুলিতে এখনো সেভাবে জনবল কাঠামো গড়ে ওঠে নাই। তাদের অর্থনৈতিক সক্ষমতা খুবই সীমিত, কারণ তারা জনগণের কাছ থেকে যে রেভিনিউজ কালেকশন করে সেটা দিয়ে রাস্তাঘাট, পুল, কালভার্ট এবং নিয়মিত যে পরিষ্কার পরিচ্ছন্নতার কার্যক্রম সেখানে করতে তারা হিমশিম খায়। সেই ক্ষেত্রে স্বাস্থ্য সেবার মতো একটা বড় ধরনের সেবা কার্যক্রম পরিচালনা করার ক্ষেত্রে তাদের যে অভ্যন্তরীণ বাজেট বা রেভিনিউ কালেকশন সেটা দিয়ে তারা করতে পারে না, এটা চালানোর মতো সক্ষমতা তাদের নাই। ওই সকল বিবেচনায় মাথায় রেখে বর্তমান সরকারের মাননীয় প্রধানমন্ত্রী বঙ্গবন্ধু কন্যা শেখ হাসিনা তিনি 1998 সালে আমাদের ডেভেলপমেন্ট পার্টনার এডিপির সাথে একটি ঋণ চুক্তির মাধ্যমে এই প্রকল্পটা প্রায় চারটা ইয়েতে সেগমেন্টে 2টা মেজর ফেজে এগুলো বাস্তবায়িত হচ্ছে। প্রথমে শুরু হয়েছিল 1998 সালে, 98, 99, 2000, 2001-এ মাননীয় প্রধানমন্ত্রী চলে যাওয়ার পরে তখন একটু থেমেছিল। এরপরে উনি বিশেষ করে 2009 সালে ক্ষমতায় আসার পর থেকে এই প্রকল্পের পরিসর আরো বেড়েছে এবং এই পরিসরে আমরা বাংলাদেশি টাকা যদি কনভার্ট করি ডলারের সাথে এখন 1572 কোটি টাকায় 2018 সালের মার্চে শুরু হয়েছে, 2023 সালের মার্চে শেষ হবে এই টাকা দিয়ে। এবং এখানে মূলত 3টা মেজর হেড আগেই বলেছি যে রিপ্রোডাক্টিভ হেলথ কেয়ার সার্ভিস, অ্যাডোলেসেন্ট হেলথ কেয়ার এবং নিউট্রিশন, এই 3টা সেবা কার্যক্রম অব্যাহতভাবে এই প্রকল্পের মাধ্যমে পরিচালনা করা হচ্ছে। এখন আপনারা বললেন যে আমাদের যে সকল আছে মানে যাদেরকে সেবা দেওয়া হয় সবার তথ্য কোনো ডেটাবেজ আছে কিনা। হ্যাঁ, এই ডেটাবেজ করার জন্য আমরা একটা এমআইএস ফার্ম নিযুক্ত করেছি। এই এমআইএস ফার্ম আমাদের যে স্যাটেলাইট আছে, আমাদের যে প্রাইমারি হেলথ কেয়ার সেন্টার আছে যেটাকে আমরা পিএসসি বলছি, এবং যে সিআরএসসি আমাদের কম্প্রিহেনসিভ হেলথ কেয়ার রিপ্রোডাক্টিভ হেলথ কেয়ার সেন্টার আছে, প্রত্যেকেই যারা সেখানে কাজ করে যে ধরনের সেবা যতজন পায় প্রত্যেকটা সেবা সরাসরি লাইভ যেটা আমাদের ন্যাশনাল হেলথ এমআইএস এর সাথে আমরা সিনক্রোনাইজড করে তাদের সাথে আমরা লিঙ্কেজ করে দিয়েছি এবং সেখানে চলে যাচ্ছে। এবং আপনি শুনে খুশি হবেন যে এই 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 সিটি কর্পোরেশনের পৌরসভাগুলি তারা আবহমান কাল ধরে প্রাথমিক টিকা কার্যক্রমটা তারা করতে ইপিআইটা, এখন যখন প্যান্ডামিক শুরু হয়ে গেল আমাদের দিতে হবে অধিক জনসংখ্যাকে কোভিড এর টিকা, সেই টিকা দেওয়ার জন্য আমাদের আরবান প্রাইমারি হেলথ কেয়ার সার্ভিস ডেলিভারি প্রজেক্টের এই কেন্দ্রগুলিকে ব্যবহার করে প্রায় 78 লক্ষ জনগণকে টিকা প্রদান করা হয়েছে। এটা একটা বড় তথ্য এবং আমরা এটাকে ম্যানুয়ালি পাঠাতাম হেলথ এমআইএস-এ। পরে শেষমেশ আমাদের এই প্রজেক্টের মাধ্যমে এই হেলথ এমআইএস সিস্টেম করার কারণে এমপাওয়ার তারা এখন সেটা সেন্ট্রাল এমআইএস বা হেলথ এমআইএস দিতে পারছে এবং সরাসরি এই তথ্যগুলি সেখানে যাচ্ছে। আমাদের এই আপনারা জানেন যে সিটি কর্পোরেশনের বাজেটের কত অংশ এখানে ব্যয় হয় এটা তারা স্পেসিফিক এখনো করে নাই। আমরা জানি যে তারা তাদের লোকাল ইনিশিয়েটিভ থেকে তারা কিছু কাজ করে, মশা মারার কাজ করে, তারপরে আপনার ডেঙ্গু মশার প্রতিরোধের কার্যক্রম গ্রহণ করে, ওয়াশ কার্যক্রম আছে তাদের, কিন্তু এটা বাজেটের তাদের যে বাজেট তার কত অংশ সেটা জানি না। তবে আপনাকে বলি যে যদি এই প্রজেক্ট শেষ হয়ে যায়, বর্তমান এই ডিপিপি অনুসারে এডিবি মোট 5টা দিয়েছিল, কি বলে এটাকে মাইলস্টোন দিয়েছিল, যে এটা অর্জন করতে পারলে তোমাদেরকে আমরা 20 মিলিয়ন ইউএসডি, বাংলাদেশ টাকা 170 কোটি টাকা দিব তোমাদের কনস্ট্রাকশন অফ সিআরএসসি এন্ড পিএসসি করার জন্য। তার জন্য কি করতে হবে, তোমাদের যে গভর্নমেন্টের অপারেটিং বাজেট যেটা রাজস্ব খাত থেকে বাজেট একটা হেড ক্রিয়েট করতে হবে। এটা খুব কঠিন কাজ ছিল, স্যাররা হেল্প করেছেন এবং আমি যেহেতু ফাইন্যান্সের কাজ করেছি অনেক কষ্টে এখানে একটা আমার অপারেটিং বাজেটে 2টা মেজর হেড ক্রিয়েট করতে পেরেছি, একটা সিটি কর্পোরেশন আর একটা পৌরসভা। এই হেডে গত অর্থ বছরে মাত্র 2-2.5 মাস সময় ছিল, তখন আমরা 5 কোটি টাকা বরাদ্দ করতে পেরেছিলাম। ইট ইজ দ্য ইনিশিয়েটিভ, ফার্স্ট ইনিশিয়েটিভ ফ্রম দ্য মিনিস্ট্রি অফ ফাইন্যান্স। তারা সিটি কর্পোরেশন গুলিকে 3 কোটি টাকা দিয়েছিল, পৌরসভাগুলিকে 2 কোটি। বর্তমান অর্থ বছরে মোট 14 কোটি টাকা বরাদ্দ করা হয়েছে। যদি এই প্রজেক্ট নাও থাকে তাহলে গভর্নমেন্ট এক্সচেকার থেকে প্রতি বছর নিয়মিতভাবে সিটি কর্পোরেশন ও পৌরসভাগুলি একটা নির্দিষ্ট অ্যামাউন্ট পাবে। ইট ইজ এ গুড জেস্টার ফ্রম দ্য গভর্নমেন্ট। বাকিটুকু তারা তাদের নিজস্ব রেভিনিউ দিয়ে, কারণ সিটি কর্পোরেশন গুলি বা পৌরসভাগুলি সেলফ গভর্নমেন্ট, তারা নিজস্ব অর্থায়নে এই প্রকল্পটা পরিচালনা করতে পারবে বলে আমরা বিশ্বাস করি। এবং তাদের স্ট্রেংথেনিং এর জন্য এবং এই যে সাস্টেনেবিলিটি ডেভেলপমেন্টের জন্য এই প্রজেক্ট থেকে আমরা একটা ইউএলবি ফার্ম নিযুক্ত করেছি, তারা তাদের সাথে অব্যাহতভাবে আলোচনার মাধ্যমে এই কাজগুলি করে যাচ্ছে।
থ্যাংক ইউ। না
স্যার, ছোট্ট স্যার, সম্পূর্ণ একটা প্রশ্ন স্যার আগে।
এটা করতে পারবো, এটা
প্লিজ আস্ক দ্য কোশ্চেন ইন
দরকার
ইংলিশ।
ছিল।
ওকে প্লিজ।
Okay, so
Two friends from other countries, they are in here.
so
If you have any queries or any observations.
now we will come to it. We have another presentation. So Andrew, I'm requesting you have a presentation. So please come here. Dr. Andrew Smith.
Thank you very much. Let's see if the technology works. Super. So good to meet you all this afternoon. I actually lived and worked in Dhaka in Bangladesh for 5 years. I was the co-founder and chief commercial officer of the largest digital healthcare provider in Bangladesh, Telenor Health. And now I'm working with a healthcare advisory company that's bringing some big investments to Bangladesh. So I care about the country a lot. Next slide. What I think I'll share today is some examples of how digital healthcare technology is being used to accelerate the kind of urban health progress in Dhaka, particularly, and in other urban centers of Bangladesh. The slides don't go forward. Do I need to push something? Super. So very briefly, who were or are Telenor Health? So across all of Bangladesh, we delivered about 2 million digital doctor consultations across the nation, had 6 million members, did specialists, cardiology, pediatrics, gynecology, as well as GP doctors. We also developed different services like diabetic care plans, child development plans, but that was for the nation as a whole. And the majority of users were in rural Bangladesh, where there's 80, 90 million patients and very few doctors. But for today, here are several case studies of what we did in urban areas. If it's going to work. It's really not clicking. Okay, so the huge project that we did for the garment sector. So as you would all know, it's the export engine of Bangladesh, 3-4 million jobs there, huge amount of foreign currency earnings come from the industry. But the health of the workers is often difficult and challenged. So we did a 2-year project with BGMEA, the industry association, with Save the Children, with USAID, to deliver healthcare services to the factories. We did 50 factories with digital doctor video booths. So you can see on the screen there, bringing the gynecologists, the pediatricians, the cardiologists, the medicine specialists directly to the garment workers. And we covered 150,000 garment workers with micro health insurance. During the 2 years, around 30,000 workers took advantage of all of those services. And we integrated it with some of the local Dhaka North City Corporation provided clinics and other services. So giving the workers not just doctor consultation, but then the follow-on medication, follow-on diagnostics from some of the local DNCC provided clinics with NGOs. Another project that we worked on in urban Bangladesh. The slides don't move. Next slide. Okay. So this is with the Shakti Foundation for Disadvantaged Women, who have got, I think, 84, 85 maternal and child health centers, I think perhaps 15 or 16 in Dhaka itself, and the rest in other areas. So again, we brought the digital doctor, digital specialist directly into the community clinic, so they could access not just the community health worker programs, but all of the specialist advice from some of the top hospitals in Dhaka. And you can see some of the specialties on the right-hand side. And for many of the women, they'd been suffering with pain after a birth for 2 or 3 years, and they'd never been able to access specialist advice. So another way of using technology to bring specialist doctors that might normally cost 400 taka or 600 taka, 800 taka for one consultation, directly to the community for a very affordable price, just 30, 40 taka, sometimes free, with an NGO partner. And that was scaled up to about 20,000 women over the course of 2020 and 2021 during the pandemic. Next slide. This another example. So we did under COVID times in 2020 particularly, a kind of digital doctor booth combined with diagnostics. So someone could have a consultation with a doctor about their COVID symptoms. They could have a COVID test kind of there and then, and be signposted on for other help and support. Since 2020, we expanded that to other diagnostics. So you can see on the right-hand side, it looks like it's an eye scanner. In fact, it's looking at someone's retina for 20 diseases. So it can detect whether they've got diabetes, whether they've got heart disease, whether they've got whether they've had potentially had a stroke recently. So anything to do with the vessels and the kind of health of the blood vessels in the body, and it can scan for all those conditions. It's been used in China with about 8 million patients, and it's about $0.1 US for a 98% accurate scan. So we've now been deploying that in Bangladesh in several pilots to open up access to screening for diabetes and heart disease, again, followed with digital doctor consultations. Next slide. And then one final program, which was with the Diabetic Association of Bangladesh and with Sanofi, which was basically how can you help diabetic patients, of which there are millions in Bangladesh, manage and improve their condition. So at the start of this program, only 23% of the patients were managing their diabetes properly. The vast majority, the diabetes was out of control, risking amputations and loss of limb, loss of sight. But by the end of 6 months on the program, 73% were in control of their diabetes by combining some offline care from local NGO clinics and then the online support of the digital doctor to help them manage their condition. So again, bringing some of the kind of urban slum communities and nearby slum communities access to top specialist advice without having to leave their home or leave their kind of workplace. Next slide. And then some other projects that we did that we haven't got time today to go into. So there were about 200 pharmacies where we repeated some of the same models. So took the digital doctor consultations, took some diagnostic devices, deployed them to urban pharmacies where, often they're the frontline point of care where someone might go first. So use that as a health hub. And then we equipped about 5,000 community health workers, including from Care Bangladesh, Save the Children, and 3 other NGOs, with digital health tools. They could use all of this, digital doctor or specialist advice and bring it to their local community that they were supporting, as well as home medicine delivery, home diagnostics. So I think that was, a really exciting 2 or 3 years when I was with all the partners in Dhaka. But for the last year, I've been working in China and in Korea with a couple of big funders who want to invest in a very big way in Bangladesh. And there's one final project that I'll show, which is really a joint effort between the mayor of Dhaka North City Corporation, the LGRD. It's now in the annual development plan of the government of Bangladesh for this year until July 2023. Next slide. And it's to take a lot of these individual programs and really scale them up in a big way for the people of Dhaka North. Next slide. And it will basically have 4 components. So the existing clinics that I think we already heard referenced earlier today in the other presentations, basically add in some of those digital services to those clinics. So whether it's specialists via video, some of those diagnostic technology, where you can look for breast cancer, diabetes, heart disease, $0.1 in just 1 minute. Introduce that to all of those urban health clinics, introduce a new kind of digital hospital. So there's a market building that the panel will all know that is currently a kind of COVID isolation hospital, but the vision of Mayor Atik and LGRD is to upgrade that to be a fully functioning digital hospital with 12 or 13 departments, and again, leverage the latest IoT technology from China and Korea to give great services. There'll be mass screening for 2 million people across the whole of Dhaka North to look for all of those hidden disease burdens that are there, and then use the community health workers that are already there on the ground to help people manage their diabetes or heart disease or TB. Around 200,000 people will be funded to have health programs dedicated for their diabetes or heart disease. Next slide. And the desire I know from Mayor Atik and from the LGRD kind of partners is to really make this impact several big health metrics. So improve maternal health and child health, also improve how people are managing their diabetes or heart disease, reduce the out-of-pocket health expenditure that we heard from colleagues in the last presentations, and also reduce some of the prevalence and hospitalizations of things like dengue, which actually have a huge hidden cost on the population of Dhaka North. I think there's maybe some more to reveal. Yeah. So you can see here some of the big health goals that Mayor Atik and LGRD and the whole of the government of Bangladesh want from the program. And I know that the funders of the program from China particularly are very excited to see the impact that it will have in the next 2-3 years. So I think we've seen a lot of innovations in urban health in Bangladesh, but the the best days are yet to come. Yeah, so thank you all.
Thank you, Andrew. It was very informative. And I would request you to have all the visions you are seeing with Mayor Atik, you should share with other people in the same sector so we can have a coordinated effort. Thank you very much. It was very informative. So now we have finished all the presentations, and for the sake of time, I will ask or directly go to the panelists. First, Dr. Johir Islam, Senior Health Specialist, a Senior Health Advisor from Embassy of Sweden in Bangladesh, to give his views. And Dr. Johir.
Thank you, Marco Bhai, Honorable Chair of the session and other speakers, and also the audiences. Like they are the most valuable, because I appreciate your patience, and I'm seeing like the tiredness in your eyes. So I should not take long. So once following Louis Icahn, who is a great architect, he said true discussion is, or true learning is possible when the discussant does not know that he's a discussant, and audience also does not know that they are also audience. So I think this small group is like creating that mood. So for me, the real challenge is the title. The title is Spotlight on Bangladesh, fine. And then Community Health in Action. But I'm not finding community that much. I'm seeing primary healthcare in action. But one of the 4 principles was community participation. And it will help you, I think, particularly the international participants. Why, when we talk about urban health, it's different than when we discuss in the plenary and other sessions. So there you will see most of the discussions are around blue space, green space, walkability, bicyclability, urban built environment, pollution, and other things. All these are also problems of Bangladesh. But even the basic problem to provide primary healthcare to the urban poor is a real challenge, because 2 projects were presented and 3, in fact, exciting presentations were made. And all these are important. I can give you an example, like our Honorable Project Director, he said that in Dhaka, 220 million people lives in Dhaka. So if we compare with our rural Bangladesh, because once Bangladesh was completely rural, and we have a very good infrastructure, though some are old, new, but at least for, let's say, 6,000 population, we have a community clinic. For 20 to 30,000 population, we have Union Family Health Welfare Center. For 300,000 to 500,000 population, we have Bupuzela Health Complex. And then we have secondary hospital and tertiary medical college hospitals. Since once it was a rural Bangladesh and urbanization was not that much thought. So urban area, like all patients are going to the tertiary hospitals or secondary hospitals. So primary healthcare infrastructure was not built the way it is needed. And if we calculate, let's say for 20,000 population, we need 1 small primary healthcare center. So we need 1,000 primary healthcare center. But unfortunately, if you look at our primary healthcare center in Dhaka, it will not be more than 100 even. So most of the people go to the pharmacy, and pharmacy means not in Western countries, the pharmacy, a medicine shop. Medicine vendor is like a selling medicine. Some has, let's say, 7 days training. Some has 7 weeks training. So it's almost, some does not have even a training. Through apprenticeship, they have learned all these things. So that's why urban area, there is a big infrastructure gap in terms of, if we think from the health system perspective, big human resource gap. Our project director said, though the mandate is with urban, like a Ministry of Local Government or urban local bodies, but they don't have the human resources. They don't have like the required budget. And they are, in fact, in their priorities, it does not come in their mind. Already he shared, because they have so many things to do. So in this situation, how community is engaged, like in technology, we are seeing some community health workers who are linked with the market or selling the medicine, like a care. So they have trained some workers, those who will be like sell the services. In the urban primary healthcare project, there are ward committees, ward coordination committees, but still like since my, I would say I'm in a way beneficial from both the projects, because we are funder of both the projects. So the ward coordination committee takes place, but not that frequently, the way we expect. It's a kind of, let's say, from tokenism to a minimum level participation, not the way we think community empowerment. So that is one challenge. And in the Alu Clinic, you will see the facilities close to the community, and community has some opportunity to provide feedback. But the way we think it should be community managed and or community engaged, community empowered healthcare system. So still we are like so far away. So there are different levels of engagement, like community representative to some extent, maybe like he's talking about mayor, but that's more like in German, there are two words, Gemeinschaft and Gesellschaft. So one is community, another is society. So, and so some are guided by law, some are more informal, like a kind of thing. So here I see lots of opportunity to engage community. Like in your last presentation, you have shown the Uberization of health services, and COVID has provided an opportunity. And it's important, but what Margub Bhai said, that in the health system, we need to connect all the dots. Otherwise, this fragmentation, I think, will not reach us anywhere. So for primary healthcare, this is a center of universal health coverage. So it should be the centerpiece. And if then a common package should be developed where like each citizen should have the entitlement to have the basic like a primary health care, and how it will be delivered, like urban slum, urban population, they are not hard to reach population. They're hard to access population. They cannot access the services due to financial and other barriers. So that is also important, how like the vision is also required, how we can reduce the out-of-pocket expenditure. Not only reduce, I would say, gradually we can even like make it zero, I would say, out-of-pocket expenditure. Because Bangladesh has taken some vision that which path they should choose for a universal health coverage, the social health insurance or the tax-based system. Broadly, it seems more on the tax-based system. So, however, I think for community engagement, I think the app's idea came out. So maybe like in the Telenor can help a lot, so that people can rate, like give 4-star, 5-star, like or other feedbacks to different clinics, even public, private, all like this. If possible, like engage like authorities like in a dialogue, because technology helps a lot, but I think political will, political commitment is very important from the top, but also from the bottom, community awareness, their entitlement, and also community mobilization, that is also important. So thank you very much. I should not like make you more tired. Thank you very much.
Thank you, Dr. Zahir. Before going to the our chair, if anybody has any question or remarks you want to make, now is the time. So Thank you very much. Now I am requesting Mr. Mustaqim Billah Faruqi, the Additional Secretary to the Bangladesh government, to say his final remarks and conclude the session. Thank you.
I think I can conclude it from here. No problem, because you assigned me instantly to present about the session. So I to be very small in speaking, and I heard we see and we heard the presentation from many of our colleagues and from Bangladesh, especially Ruji Alam from PhD, Nuri Masuda Begum, Moitri, Nari Moitri, and from Telenor, and Mr. Alauddin, my colleague and the project director of Urban Health Service, Primary Health Service project. The presentation was very good, and that was very elaborate presentation was there. But a short presentation was from Telenor, but that was very inclusive also. And we come to know about the project is going on July 2023. Okay. I'm happy to hear some information or see some information which was not in my knowledge about Bangladesh also. I come to know here with the, from our Bangladeshi peoples. This is really new to for me. But what things I believe, the healthcare, urban healthcare or healthcare, the same things. It's needed for the all. But we are thinking here for urban healthcare because urbanization is going on. And the people who live in the urban, they need the healthcare. For whom? For all. But we emphasized to give the service for the poor who really need the service from the government really. It is the government responsibility to provide the health service. So there is a strategy, there is a mandate. My colleague mentioned it. It is the mandate from of the health ministry. And at the same time, the law gives us the responsibility to take care of the urban primary health care for the local government side. And my Johir, our colleague, really he mentioned in the rural area, we have a good structure in Bangladesh. In comparison with other country, I think it's the more better structure we have. And we are providing our service through the 3-tier, he mentioned it. And the 4th tier is tertiary tier. But all the people, all the tier, it is established in the urban areas. District, also urban area. Upazila, the subdivision in the subdivision, sub-districts of the of Bangladesh, it's all the urban area. And the tertiary level city corporation, where the city corporation is established, it's all the urban area. So there are a lot of 112 medical colleges in Bangladesh, and 70 of them are public medical college. There are a medical university in Bangladesh, you know, and there are a lot of hospitals also everywhere, all the providing the service in the urban area. So in the local rural area, we have the community clinic, and the urban area, all the establishment, medical establishment is there. So we are trying to provide the service for the people. And you know, in the pandemic time, we really established our system, how we can engage the community, how we engage our community people through the local government institutions. You know, we are the fifth of the vaccination country all over the world. So it's our credit, at the same time, our initiative, leading by our President, Prime Minister. We really did it, but done it very accurately. Fifth vaccinated country of the world. So we have the initiative and we have the establishment also. But in fact, in the rural area, if we separated our responsibility differently, primary health care is up to that marks. This is the primary health care. We know initially who feel discomfort, he should have the access to the doctor. This is the primary health care. If it is primitive or preventive measure could be the primary health care. So these two we can attend separately, but we can establish our medical assistance or establishment in their medical college also, premises also, in the hospital also, and other way we can establish separately. But there is we need a policy advocacy. What and how we can provide this service. This is the policy advocacy we need, and community engagement is there is community engagement system. He mentioned World Community Committee in our urban area, in the city corporation and the municipality. There is a standing committee. We call it a standing committee, who were really very nicely formed, but they are not so proactive. But we can make them active. This also depends on the policymakers and their initiatives. So we can develop or we can award them to take the initiatives, and it could be if the policymaker become aware, if we take the decision how we will provide our service to the urban people, then we can do better service for the people. And there is a scope, there is a really better scope to advocacy to make the policy and strategy. It's the needed for Bangladesh. What I feel as a additional secretary of the local government division, I feel we have some gaps, and gaps only how we will like to provide our service to the people. This gap, if we can fill up this gap, and we can accept some policy advocacy from our development partners also, and especially the UNICEF. There is a Margub. They are providing a lot of support to develop our primary health care and other. So if we can really accommodate the policy advocacy from the other development partners and others, then I believe our government and our community, our government or our state can do the right things to provide the primary health care. So thank you. With these few words, I like to go to the end, and I like to give the big thanks to the audience, especially the valuable audience one from the Spanish.
She's from United States.
United States. Okay. Very big and powerful country. We should be very happy to get you.
Also like for healthy city in Bangladesh.
Okay. She has some interest. Okay. Thank you very much to be present here, because you are working with Bangladesh Resilience City, Green Resilience City. No. Okay. There is a lot of program we are receiving from your side, not your side, but all the World Bank and other development partners. We are receiving some advice to make our country very resilient, climate resilience, green climate resilience, such type of program or advocacy. It's also needed for Bangladesh. and we are waiting to receive. How we'll receive, how extent we will receive, how our capacity, what extent we have the capacity to receive that type of advocacy. We are thinking on it. So when we'll be develop our mental makeup to receive your advocacy, we will absolutely we will receive that advocacy from your side. Okay, thank you. Okay. Oh. Okay, you're welcome. Okay, you are most welcome. And if I be there in the local government division, then I would like to work with you. And thank you very much. Thank you very much. With this few word, I like to put the end. Thanks.
Thank you.